Hey guys, Dr. Andy here. Today we are joined by Dr. Sam Hatchel. He is a physical therapist here in Burlington, North Carolina. We're going to get into functional and structural diagnosis today. But today, before we get started, Sam, do me a favor, introduce yourself, tell everyone a little bit about you.
All right, so I'm Sam. I've been in physical therapy for 10 years, and most of my career, if not pretty much all of my career, has been outpatient orthopedics. And currently, I work for Renew Physiotherapy. We are a physical therapy provider, the majority in North Carolina and also upstate South Carolina. And we offer more of the manual therapy approach. We do the
Yep.
one-on-one treatments. And we are located in most, if not all, the O2 fitness facilities.
Yeah.
Um,
So you said manual. I said one-on-one. That's kind of what I love about you because I feel like, and I'm not trash on physical therapists or anything like that, but
mhm,
it's just so many of them kind of just do this whole like puppy mill kind of a thing
mhm.
where you
Yeah,
don't actually get a lot of time with the physical therapist. I mean, it's the same thing you can say about chiropractors, honestly, is
sure,
that sometimes you don't
sure.
get a lot of time with the doc himself or herself, sorry. But I love the fact that when the patients come see you, they see you for their entire time.
Yeah, I think it's kind of our company vision is to break the mold a little bit,
Love it.
get to know the patients, get to know everything about them, how they move, what feels right, what feels wrong. And for us to do that, we have to have time to spend time with our patients, right?
Yeah, exactly. Yeah.
You know, giving we do, obviously we do your standard skilled exercise progressions and
Mhm.
therapeutic procedures and stuff like that. But a totality, all-inclusive approach is, I think, best for the patient. And it
For
also
sure it is.
helps, I think, with compliance too.
Mhm.
Having that tactile component as in human nature is pretty huge. We found that out in 2020. So
We did. It was a weird
yeah,
time for manual
it
therapists,
was.
right?
It
It was
was.
an
Yeah.
odd time for us. So
Yeah.
10 years
10 years. Yeah. Yeah.
graduated.
Be 10
Because I
years basically in January. Yeah.
okay. So I graduated December of 2022. So I literally
Mhm.
just had my 10-year anniversary. So that's pretty cool.
Nice.
So what led you into physical therapy?
Yeah, so initially, I wanted to work with like collegiate athletes, basically
Mhm.
doing strength and conditioning, stuff like that. I've always been interested in movement and movement science. And then I had an internship where one of my professors says, "Hey, have you looked into physical therapy?" And I was like, "Well, no, I haven't." And then the very first patient I saw, I'll remember it like it was yesterday. It was a mirror training, like phantom limb patient that
Okay.
had been a recent amputee, and I was like, "What is going on? Like, how is this is crazy?"
Ooh, interesting. Okay.
And then yeah, and then started to learn more about like different areas and different opportunities within physical therapy.
Yep.
Your inpatient neuros, your skilled nursings, your outpatient orthopedics is where I landed,
Mhm.
outpatient orthopedics. So,
But it's
yeah,
cool
that's
because
kind of what. Mhm.
I was gonna say it's cool because you still get the opportunity to work on the athletes. You don't have to be the certified conditioning strength coach, right? You can still
Yeah,
work with them.
yeah, yeah, and to really just take it a step further is I found that I'm selfishly more I get more kind of gratitude helping someone that can't even walk, right? I mean,
Sure, sure.
they come in on crutches and then 4, 5, 6 months, whatever, however,
Yeah.
post-operatively it takes, um, they're going up and down stairs, they're squatting, they're getting on the
Mhm.
floor with their kids, and all areas of outpatient, I think, give you that component where you can work with some folks that have super high goals and some folks that literally just want to learn how to walk and stand and not fall and be out of pain. So that's why I kind of I'm glad I'm ended up and I'm glad I'm
Yeah,
kind of in that
exactly. Yeah.
outpatient orthopedic type of scenario.
So you and I have been doing it long enough that we realize we tell the same jokes over and over, right?
Yeah.
And one of my common jokes is, I've got a perfect track record. Like anyone who walks in can walk out,
Sure.
right?
Yeah.
So
Yeah. Yeah.
far. And we've
Yeah.
had a couple of those miracle cases, like you're saying, maybe 4 or 5, where they could not walk in,
Yeah.
but they could walk out, right? And it's
Yeah.
not because we rose them from the dead, it was because someone dragged them in.
Sure. Yeah. Yeah.
And those are fun. Those
It
are
is. They
certainly
stick
the
with
ones that
you.
you put up on, yeah, the ones you put up on the
Mhm.
wall as like, look, I did that. I did that. I'm proud of myself for that one.
Yeah, and especially the patients that stick to it is gratifying as
Mhm.
well, because it's not easy.
No.
Sometimes coming in broken is, I say broken, but
Yeah, I
sometimes
follow you.
coming in, with debility is tough. I mean, it's
Mhm.
tough physically, it's tough emotionally. You're out of work, you're not able to hold your child, you're not able to tie your shoe. I mean, stuff like
Yeah.
that.
It can be
And
small and it can be large,
it
right? In
can be
terms of like,
big.
oh,
Yeah, the
I
people
yeah.
that stick with it makes it a lot easier on every day is easy to come to work, but to be that that more engaged in what you do, I think is
Yeah,
uh
100%.
a good
Yeah.
reason why I like to call myself a physical therapist. So
Yeah. Perfect transition then into that. And my next question is, so who is it that you are passionate about helping, or who do you specialize in helping?
I have some specialty training in like dry needling. I do concussion. I really like and enjoy like upper extremity type of
Mhm.
rehabilitation. Um, I'd be lying if I said I didn't really enjoy post-operative. I really enjoy post-operative.
All right.
I like kind of following that post-op protocol and kind of seeing them, come from a sling to lifting a weight over their head, or being in a leg brace, coming in on crutches to, squatting down and stuff like that. I mean, those are the ones that I really thoroughly enjoy. But basically everything that comes through the door is a challenge, I think,
Mhm.
in its own way. And to be challenged daily, I think is good. I mean, I think it's good
Yeah.
for the profession, for the career path, basically. And then
Well, you have to be challenged every single day, because what
yeah.
people, I think, maybe on the outside don't realize
Hmm.
is how repetitive our job can be.
Can be, yeah, it
It
can
can
be.
be. It doesn't
Yeah,
have to be,
it
but it
doesn't have to be.
can be.
Yeah,
Yeah, it
that,
can be.
that's the good thing about
Um,
movement science, is you can move in any
right.
plane.
Yep.
Yeah.
Yep. Exactly.
Yeah.
So let's get into the meat of something I discussed, or something I wanted to talk about. And I actually talked about this with a different doctor as well.
Mhm.
But I thought this would be a perfect conversation to have for some of my patients or people out in the Burlington community that kind of need to hear this, because this is something that's just horribly misunderstood. That I feel like if we could communicate this a lot better with our patients in the community, they
Mhm.
really kind of have a better understanding of themselves and what's going on. And
Sure.
that's the difference between a structural and a functional diagnosis,
Mhm.
and what is causing the pain. So,
Sure.
chiropractors and PTs, would you say that we are, for the most part, treating structural or functional diagnosis?
I'd say functional
100%. Right. Yeah. That was the
in
leading
a
question right
very,
there.
very
Yeah.
large category, very functional. Yeah. Yeah.
Uh, every single day, I have a patient come in, especially the
Mhm.
new ones, that will come in and say, like, I was diagnosed with arthritis in my neck or
Mhm.
with a disc bulge 10 years ago,
Right.
and that's what my pain is coming from.
Mhm.
And that's what we would call like a structural diagnosis.
Sure.
The functional aspect of it is, and very, very rarely having any pain from that actual
Mhm.
structure.
Yeah.
The vast majority of pain is coming from the functional aspect of, we have lost some of the movement, or our neck is stiff, possibly because of the arthritis, right? I kind of say maybe
Right.
it's like maybe it's lowered our ceiling. Maybe we might not be able to get you to
Right.
100%. Maybe we can get you now to 90.
Right.
But the answer to, like, my pain is coming from my arthritis, that's why I'm hurting, is like, no, you got to move more.
Yeah, and I think one of the ways that we can um, kind of de-escalate the black and white ink on the script, right?
Yeah.
Sometimes that's, patients can get very just centered around, oh, I have disc bulge, I have,
Yep.
whatever it may be. So I think what we try to do, at least, or what I try to do, is let's try to aggravate and alleviate, right? So
Yeah.
if we can aggravate and alleviate, that means it can you have a symptom modification position, right?
Exactly. Which means it's
And
immediately functional.
right. So,
Yeah.
if we can, especially if we can alleviate that,
Yep.
that really that can really kind of pull back down some of the anxieties of starting. Especially the folks that are just starting, like I've never had
Yep.
physical therapy or anything, before. I think that's one of the things that we really try to see, and that's good for us as an assessment tool as well, right? So if we have
Hmm.
something obviously that's a red flag that doesn't necessarily fit, that's a different conversation, obviously. But
Yep.
I would kind of say that's a little bit more few and far between. I think most
Yeah,
people that
definitely.
are making it in the door, most people are, have a history of something, and
Hmm.
if we can aggravate, but for sure if we can alleviate, then we can get some progress going.
Yeah. Well, let's clear the muddled water, the muddy water. So
Mhm.
I even sometimes have a difficulty if it's in the moment explaining or trying to explain to a patient what a functional diagnosis is. How do
Mhm.
you go about doing it? How do you describe to your patients or give examples, and help patients understand what a functional versus structural diagnosis is?
So same scenario, right? So I, I can't give you new tires, but we can try to make your car better alignment, right? Type of thing,
Sure,
or
sure. That one never fails. That like,
yeah, yeah,
it's annoying how
yeah,
perfect that example is. Like, I
yeah,
hate using it. I hate using the car
yeah. The car,
analogy.
yeah,
I hate it, and at the same time, you go back to it over and over because
yeah,
it's at the same time it's so perfect.
yeah. I mean, I think it's like I think like kind of like a longevity type of thing. Like, this is something that can be addressed with some movement science of some sort, right?
Yep. Yep.
With some therapeutic approach.
Yeah.
If we can kind of narrow in and again have that patient just calm down a little bit from a
Yeah.
fight, right?
Yep.
And then I think that's one of the bigger things that we can get. We could call it buy-in if you wanted to, but basically, if we can give some of our patients education is key.
Sure.
Google will get you so far. It
Hmm.
may lead you the right way. It may lead you the not right way. But I think that education component is in that functional type of
Hmm.
recovery rehabilitative
Yeah.
process. I think that's kind of primarily what I try to do with my patients, and then once they can kind of get in and get a little bit more comfortable and um, notice some subjective but also some
Hmm.
objective improvement, because they live in their body every day. So you
Yep.
measure them and you say, well, you've got 100 degrees of shoulder flexion. 4 weeks later, well, you've got 160. What does that mean to them? Well, it means they can reach into a cabinet. It means
Yep.
that, you know what I mean? They can wash
Yep.
their hair. So subjectively and objectively, we want to be kind of linear.
Hmm.
So a super wise therapist told me one day, if you move better, your pain
Goes
pretty
down.
much
Yep.
has to go down, right?
Yeah. Yeah.
So
I try and
function and debility are inverse.
exactly. So I'll first, have you read Annie O'Connor's book World of Hurt?
uh,
Okay,
no.
it's fantastic, but in the foreword there is a quote from like the vice, not the vice principal, that would be a school, right? I
Yeah,
don't remember what's it like
don't
as,
don't don't go back there, man.
yeah,
Don't take it back there.
assistant to the person in charge of
Sure.
the American Academy of Surgeons.
Okay.
I think it was like, or maybe it was American Academy of like orthopedic surgeons, something like that. He said, throw out the structural diagnosis. Like, I don't care. Obviously, I'm mashing up his quote, but what he says in a nutshell is, it doesn't matter what your structural diagnosis is. It doesn't matter what actual tissue, if we're talking joint or muscle or tendon or disc, it doesn't matter exactly what is, in theory, what we're saying is wrong in terms of what we think is causing the pain.
Right.
The pain is coming from a loss of function. So how I try and explain it to the patient is, your body is designed to move a certain way. A loss of function, especially in, let's just say, your spine, means that your spine can't move the way that it's supposed to. We have a loss of movement, or very simple, you're stiff, right?
Sure.
You've lost your flexibility. Your pain is coming from your loss of flexibility, right? And that's what this orthopedic surgeon was saying.
Right.
That your pain is coming from the stiffness. It's coming from the fact that your back can't move. If you address that, regardless of what structure is causing the pain, address the fact that the patient can't touch their toes. Get them to touch their toes, and the pain goes away. The pain is directly tied to what you said, the disability, right? The disability in this case is you can't touch your toes, or you've lost some of your range of motion. Restore that range of motion, and you get your life back. The pain goes away. That is the definition, or like the synopsis of work on function, or the functional diagnosis.
Right. Yep. Agree 100%.
So what do you do in your office? What in terms of, how does manual therapy and how does therapeutic exercise accomplish that goal?
Yeah, so basically we think passive and active, right? So passively, let me move you, let me feel what it's like, right? Tactile. Let me get some of that feedback from your body, right? And then let me help you move, right? So you help me, I help you move, and then boom, you move yourself, right? So that's that in a nutshell. Active, assisted, and passive, right?
Sometimes it's about sometimes it's about creating that feedback in the patient, so the patient can feel it. Like, oh, this is how it's supposed to feel when it's making that movement. Like,
Yep. And then vice versa, this is how it should not feel.
Yeah.
Because sometimes people learn by mistakes way faster than they learn by their successes, So yeah.
Well, thank you, Sam, today. Where if someone is in need of a physical therapist here in Burlington, how do they get a hold of you?
Yeah, so you can go to our website. Like I said, I'm located within the O2 Fitness. It's in Newmarket Center. Everybody knows where Harris Teeter is.
I was about to say, next to Harris Teeter.
Yeah. And we offer 20-minute free consultations to kind of get people started. We accept all major insurances. Like I said, we do 45-minute one-on-one treatment. It's me and you, right? There's not other folks laying around waiting to get some some instruction and stuff like that. Perfect.
So, speaking of, I do have another one for you this afternoon that I'm sending your way. So.
All right, cool. That sounds good. We'll take care of them. Absolutely.
All right. Thank you, Sam. Much appreciated, sir. You have a good, fantastic rest of your day, buddy.
Hey, thank you so much. I appreciate it.
Have a good one.